Hey, Elle. Elle, can you hear me? No, Elle, we can't hear you. I believe you're on mute. Elle, try and unmute yourself now and see if it works. There we go. I think you're off mute now, Elle.
Audio. Can you hear me still?
Yes, now I can hear you, Elle.
Okay. Wow. All right. Wonderful. So yes, I was just saying that there was a lot of technical challenges this morning. It did not do what it did yesterday at all.
I saw you in the attendees, so I was like, how did that happen? How did she get into the attendee area? But I'm glad we're in, and everyone that is on, we will be starting in 1 minute at 10 o'clock with our presentation. And Elle, I'm glad you're on and you're able to be off mute and everything's working.
Yes, yes, yes. I'm excited to be here.
And to all the participants, you cannot come off mute. You will be on mute the whole entire time. I see a couple people asking, saying they can't come off, they can't unmute themselves, but you will not be able to unmute yourself during this presentation. Only the presenters will be able to speak. Morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located in the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel throughout the presentation. If you continue to experience poor audio through your computer, try rejoining the webinar and use the I will call in telephone option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADA's website 30 business days after the evaluation closes. To access the recording and PowerPoint, go to www.fada.org, then to our Resource Center, and then on to our training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credit earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credits for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADA's website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADA as a part of registration remains confidential. Statements of credit will be posted 30 business days after the evaluation closes. For persons completing the evaluation and attending the full webinar, completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close midnight Tuesday, March 7th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, you needed to include your Florida license numbers for reporting to CE Broker when you registered for this webinar. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. And now I'd like to welcome our presenter, Worsham L. She has nearly 15 years of experience empowering diverse populations of vulnerable youth and their families in medical, academic, residential, outpatient, substance use, and child welfare settings with trauma-informed care. Elle is a licensed clinical social worker and certified trauma family professional. She is the co-founder and CEO of Lotus Trauma Care, a Southside Chicago trauma provider. Elle was an adjunct lecturer and field consultant at the University of Chicago in Crown Family School of Social Work, Policy, and Practice. She received her bachelor's in psychology from Loyola University, Chicago, and is concentrating in child and adolescent development. She received her master's in social service administration from the University of Chicago, specializing in the treatment of complex trauma. Elle is passionate about educating professionals and caregivers on the impact of complex trauma and has trained over 1,200 professionals across the various social services settings in trauma-informed care. Now, Elle, I will turn the presentation over to you.
Thank you so much, everyone. I'm so excited to be here with you all. All right, so I am unable to see the presentation for some reason.
Eric, can you assist there?
Anywho, well, thank you everyone for your patience while we get the technical stuff situated. So what we can do maybe is I'll just skip ahead a little bit and just engage everyone right now as we get our morning started and get this technical piece solved. So I'll have a question for everyone before I introduce myself and kind of talk a little bit about what we're to expect today. When we think about and check in with our energy in our day, where would you say your mood is? And if it were a weather forecast that you can choose, what would that forecast be to represent your mood? Also, let us know what setting you're working in so that as we are going through the presentation and discussing, I can connect what we're talking about to the context that you find yourself working in today. So again, what's the weather forecast for your mood today as we begin on this Thursday morning? We have sunny, ready to go. Mood is cloudy. I'm working in a gel. I can understand. Foggy, partly cloudy, windy, very sunny, sunny and warm. windy all over the place, foggy, partly cloudy, partly sunny, sunny with a chance of clouds. Awesome. So we have a great variety, but also some similarities. And it's really important as we think about the work that we're doing, especially if we find ourselves at work now, where our energy levels are and how we are experiencing the day, because that's going to impact the way that we respond to our clients. That's going to impact the way we approach the work that we're doing. We have working in prisons, substance use treatment, behavioral setting, adolescent girls, outpatient, an alternative school, windy, mental health settings, home visitor, nursing home visitor with mothers and infants exposed to substances. This is wonderful. I actually am trained in infant mental health as well. Substance use inpatient, beautiful day here at Fire Rescue, domestic violence advocate, addiction, MAT, DUI program. Awesome. So we have a great array of settings that we find ourselves working in. And so I'm going to do my best to make sure that we're thinking about how this work and what we're doing can apply to the different places and settings we find ourselves working in and roles we find ourselves working in, right? We find women all over the place, right? And in multiple settings. It doesn't always have to be a substance use focused setting. All right. So I am just going to check in private practice with all populations. Okay. Family intervention services.
So, El, what exactly is your problem?
I don't see the presentation and I'm not sure if everyone else sees it.
So you see everything, just a blank screen there,
I see the three boxes for myself, you, and Becca.
but then underneath there's no presentation, just a blank screen,
Yes, sir.
and your
Do you
chat.
see the layout button up at the top by participants, Elle?
Let's see here. Layout by participants. Mm-mm-mm. No, I see captions highlighting chat participants. Layout. I found layout. Let's see.
Try switching side to side or stack.
Both
See
just
if
still give me the three screens for some reason. But can everyone else see it?
yeah.
Yes.
Okay, well that's what matters, right? So with technology, luckily, we can go ahead and I'll just pull it up on a different screen here and make sure, and then maybe during the break, try to get logged in a separate device. Some people see, some people don't. Okay. No worries. So there's a newer format. WebEx haven't changed its stuff or its software, guys. So thank you so much for your patience. All right. Well, okay. So some can't see. Can I, if I'm the presenter, am I able to maybe share my screen and show it that way?
So let me see.
Should be able to.
Okay. So I will.
See if that helps. Can you see it now, Elle?
No, unfortunately not. No worry. I'm gonna. Okay. I am opening it and we'll try just sharing my screen and then hopefully that'll solve the problem so that we can all see the same screen. Okay. Share. Okay. Are we able to see the
Yeah, so we can
screen?
see.
Okay, wonderful. Let me just go to the slideshow.
Thank you, Elle. That works perfectly.
Oh, no worries. See, you got technology. We just all figured out. So I'll just need help with like if there's anything, and I'll kind of like go back and forth between the chat box, everyone. So again, thank you for your patience and participation as you checked in with yourself and told us what settings you're working in. As I was mentioning earlier, I'll make sure to do my best to hit all the different settings, or at least majority of the settings. And I encourage you to ask questions about your particular setting if necessary, because what's important is that when we walk away from the training today, we are able to see how we can use this information in real life, right? How we can begin applying and engaging with our clients, the women that we work with in different parts of our day. So you already know my credentials, but I want to tell you a little bit more about how I came into this work, because it's totally a passion of mine and more of a calling as opposed to a career. And so when I was about 13 or 14 years old for myself, I was also a youth who was impacted by a mother in using and abusing stimulants. So as was my stepfather, and that experience of lived experience influenced the desire to go into the work that I am now specializing in, which is complex trauma and childhood trauma. And in that understanding, it also helps to understand some of those intricacies, but it also helped to make sense of what the theories are and how we're looking at different things. So that is why I came into this, partially why I came into this work, because of the impact that it had on myself, and also being able to watch these things. So it comes from lived experience and then the technical experience, and being able to merge those things together to be able to promote healing amongst women, communities, and humanity overall. So our learning objectives today, as we think about women and stimulant use, is for us to learn the prevalence of women's use of stimulants, right? And there's one thing it's important to kind of keep in mind, is that the research of the subgroup of women has been more or less newer in the field of substance use, but there have been many organizations that are taking intentionality behind beginning to make sure that there are specific studies that are looking at women specifically. So we're going to look at the prevalence of stimulants for women, as well as a couple of statistics for stimulant use overall. In that, we hope to gain an understanding of the knowledge of the different evidence-based treatments that have been found to be used for stimulant use, while understanding the different gender-specific treatment considerations that we want to take when we're engaging women who are abusing or using stimulants. Another thought is that, because I think when I'm thinking about the different contexts that we're all in, is that when we think about how these different components of the treatment and the different considerations of engaging with women can be utilized in the process of engaging them, even if we are not specifically treating the substance use and itself. All right, so first we're going to begin by looking at understanding stimulant use and what it looks like, and so that we're all on the same page around what it is that we're talking about today, because some of us maybe have backgrounds in mental health, some of us may not. So when we all are on the same page, it helps to make sense of this information. So when we look at the prevalence, or how frequently these things are happening, there's been a rise in the number of cocaine and other psychostimulant related deaths. And if you see here, between 2007 and 2018, within that 11-year frame, there was over a 50% increase in the opioid use, or comorbid opioid use, right? And so this rise in the stimulant use is becoming a global challenge, but especially here in the USA. Women are entering treatment similarly for substance use at a 1-to-1 ratio, which is unheard of. Typically, men were more likely to enter treatment, and they were more likely to find themselves abusing substances. But with the specific concentration on stimulant use, we're seeing that women are now entering at a common or equal rate that men are entering, which is again something different in the trends of substance use between women and men. Similarly, women are more dependent on stimulants more quickly than men. But you can think about this being the biology, the size, right? When we look at later on what stimulants have, what impact that stimulants have on us, we'll be able to see how the different body types and weight and size, etc., biology can have an impact on how stimulants are impacting our bodies. And so we're also seeing that one of the most common reasons that women are using stimulants is for increased energy, but there are other things that are related to helping to keep up with the demands of caregiving, of running a household, of perhaps doing multiple of those things at once. And so the increase of energy can help to also offset some of the mental health challenges and mood disorders that women are also commonly experiencing with the comorbid use, or essentially using stimulants, as well as experiencing some mental health challenges. So we'll talk more about that in just a moment. Now, between the 10-year frame of 2005 and 2015, there was an increase in hospitalizations for methamphetamine, and they had tripled. Right, and it's included both men and women, but the amount tripling within a 10-year frame is pretty significant numbers. We went from 55,000 to the 6 digits, right? And so when we look at how quickly this rise and increase of stimulant use is happening, we're seeing that this is a challenge and something that needs to be addressed, and that at the very least we all want to be aware of, so that as we're seeing stimulant use, we have an understanding of how to support people who may be choosing to use stimulant use or have an abuse challenges with stimulant use. Lastly, in 2018, the related deaths were about 40%, were accounted for around roughly 40% of the overdose deaths in the USA. This statistic also includes men and women, but again, showing the significance and how dangerous stimulant use can be, right? 40% of the overdose deaths that were being recorded were related to stimulant use, right? And oftentimes we'll see later on there may be some polydrug use when we're thinking about the stimulant use. When we talk more specifically about women and stimulants, there are some considerations that we want to consider based off of gender. And when we think of gender, we're talking about the social norms and expectations and socialization that occurs. And these things must be addressed for successful treatment engagement as well as outcomes, right? And so some of them include being mindful of the pregnancy outcomes and the stigma and challenges and fears that can come with being pregnant or having used while pregnant. And so some of that is looking at the long-term health and development consequences for the child or the unborn infant. Some of that may include delayed motor development, poor language skills, cognitive and behavioral challenges as well. And so when we think about, for those of us who are working with parents or doing home visiting work, we want to think about how when we're working with women, we can help them to understand their child's development and get the resources that they need in order to get the early intervention for their children. Similarly, infants are found to be more often premature and smaller than those who are born to mothers who were not using stimulants. And so this again helping parents to understand that there are ways to make sure that the child is still getting nutrients and still getting what they need to begin thriving in spite of the challenges that the stimulants may have caused. So when we're thinking about pregnancy, not only do we want to address these challenges within the treatment process with the women, we also want to be mindful of how it impacts a woman's engagement in treatment, the likelihood of them entering treatment, the responses that they may provide during the assessment and engagement phase. The second component that's really important for us to think about when we're engaging with women that are using stimulants are the relationships, right? Specifically understanding that most often, the biological sex of woman or a woman can often find us where there is a desire for community and for connection, and this can have an impact on the demands and the amount of use. Oftentimes we'll see that the literature shows that women are engaging in substance use because of with their partner or with their family members. Additionally, there can be, and there's a correlation between the domestic violence or interpersonal violence that can happen within substance use and relationships, and that complexity and intricacy that is created within the process of helping to support the woman. And when we think about domestic violence, it's important to remember that domestic violence is not only physical violence, but also includes emotional abuse, name calling, put downs, financial abuse, making it so that one is unable to navigate without them or has to come to them, or preventing them from having access to that I had to cough, access to resources, right? It can also include sexual abuse. Just because two people are in a relationship does not mean that they are entitled to sex with one another. And so even though a relationship may exist, if a woman is saying that they do not want to have sex with their partner, then that, and their partner continues to persist in that, that is continued a form of sexual abuse or sexual assault. And so when we begin thinking about domestic violence holistically outside of the common perception of physical abuse, then we have experiences of trauma. There is a very, very, very high likelihood that there is physical, sexual, and childhood abuse amongst women who are experiencing or the use of stimulants or have been diagnosed with stimulant use disorder. And so when we think about trauma-informed care, it's very important that we are mindful of how all humans are impacted by trauma and can be impacted by overwhelming stress because of the context of humanity. But that also, when we're thinking about women specifically, there is a significant correlation of women who are abusing or using stimulants in addition to women's use with substances in general, and the correlation of trauma. So why might that be happening? It could possibly be occurring because of an attempt to cope with the trauma and the symptoms that come up with trauma. Trauma also often has comorbidity with many different disorders and mental health challenges, such as mood disorders, depression, anxiety, which is also something we know to be specifically what we want to consider when we're thinking about women who are using stimulants around the comorbidity or the coexistence of substance use and challenges with mental health, rather that be clinically diagnosed or be symptomology. And so when we're thinking about working with women, we want to keep these things in mind, right? In addition to, and another point that I want us to consider with our relationships is thinking about how do we as professionals engaging with these women create a safe context for the relationship that we're having so that we are able to see the outcomes that we desire and the women are feeling safe enough to engage or at least regulate the discomfort and unsafety that they're feeling so that they can begin to work the program and the services that you're offering, whatever that may look like. And so I want to stop for a moment and ask everyone if we can think concretely about what are some ways that we can frame questions to assess these different areas when we're thinking about working with women, right? Assessing their use during pregnancy, assessing their experiences within their relationships, whether that be with their families or their partners, and their experiences of trauma or overwhelming stress. And so again, we want some concrete examples around what are some ways, some language that we might use with women who are using or abusing stimulants as we assess these areas, understanding that these are specific components that must be addressed in the process of working with women who have abused stimulants. So I have to exit here and come to the screen to check the chat box. All right. Do you feel safe at home? Excellent question. What kind of stressors do you experience in your life? That's a really, really great question, right? Really open-ended and allowing them to just unfold what's going on. And we may need to explain what we mean by stressors, depending on the familiarity of the client and the context that we're working with. How do you deal with stress at home? Yes. Do you have any supports? Who are they? Yes, yes, yes. What support systems do you have in place? What was your experience with substances growing up? Did your parents use drugs or alcohol? Yes, yes. That parental relationships, great focus, Chris. Using the ACE assessment to gather understanding. Yes. And when we use that ACE assessment, I think it's important to preface what's going to come in the form that we're using, because it can be very triggering, and if possible, providing support and letting them know it's okay to take a break or to pause or stop. What are your triggers and can you recognize them? Yes. What support do you have? What helps you cope with the demands of day-to-day life? Support system, and does anyone in the family abuse substances? Yes. Are you able to identify when you feel safe? That's a great question. Great, great question. These are all great questions, right? When we're looking at the nuances of what the women's day-to-day lives look like, right? When we're thinking about the demands that they have on their life, when we're thinking about the relational context, the expectations of women in the world that we live in at present. Do you have safety in place? A safety plan in place? Yes. These are excellent questions. Maybe two or three more, and then we can continue on with looking at what else is important. What about your self-care? What do you do to take care of yourself? Yes, right. And the one thing I think is really important about the questions that you all are using is showing that we're looking at the human and not just solely focusing on the substance use, right? We're not assuming that the substance and the use of stimulants is the only way that they may deal with stress, or that just because they are experiencing stimulant use, that they don't have a support system, or they're having experience of domestic violence, right? These questions are very open-ended, allowing us to receive the specifics of that individual that we're sitting across from. So, excellent, excellent, excellent. Yoga, how do you identify an unsafe situation or person? Yes, 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 yes. The risk of danger, and being able to understand how perhaps the trauma that they've experienced has shown up, how aware they are of their surroundings, how likely they may be in risky situations that can potentially become re-traumatic. And that's another point when we think about trauma, right? Within the context of using substances, there is so much trauma that the person can be exposed to, right? Are you connected to a higher power? Yes, that's an excellent question, especially when we think about the component of spirituality and humanity being able to heal, right? Spirituality, not meaning that the we're not asking for any specifics around a religion, but instead an understanding of something greater than what may be outside of you has been found in the literature to be very helpful in helping people with resilience, helping people with coping, helping people with finding motivation and hope and moving forward. Is there a signal in place that warns danger? Yes. What you believe versus what you know. Mhm. I would love to hear more about that question. We can flesh that out a little bit, as far as like what it is that we are seeking to understand with the client. Okay, okay. Do you want the help, or do you know where to go? So when we're thinking about, excuse me, the services that we're offering, right? Is there anything that you need right now? What would be helpful? What type of services would be helpful, right? Do you have resources? Would you like me to provide you with some additional resources to support meeting that goal? All right, these are great questions, right? So we're thinking about how do we engage women specifically in assessing the different areas and components that we want. Another thing that's really important to consider when we're thinking about working with women and treatment with women is looking at how, especially within the context of substance use settings, how we can incorporate the address. Not only assessing but also maybe addressing some of these things. So the literature looks at how to maybe use job training programs or having childcare available, because sometimes, when we think about the relationships and the demands, right, at times children can be a challenge and or barrier to consistent engagement in treatment, right? Childcare, specifically being the challenge. So there's so many intricacies that come into play when we're thinking about working with women in the context of treatment, or working with women who have experiences of stimulant use, whether it be a diagnosed disorder or using or abusing. When we look at women in treatment, we're seeing some trends. We're seeing that women who seek treatment for substances are often younger, have lower education levels, lower incomes, are less likely to be employed, less likely to live alone or possibly be involved with the legal system. They're also more likely to be a housewife, married, or living as married. So when we think about this previous slide around how important relationships are, right, and the demands and the impact that that can have on use, it also says that they're more likely to have children living with them. And we're again thinking about the how having children, not only when we think about pregnancy, but post-pregnancy, the demands of taking care of children, the impact of our substance use on children, the subsequent responses and guilt or shame that comes with, or stigma that comes with the impact that a woman may be having on their child when abusing substances, having a partner using. And again, I want to highlight that we also see a high correlation when women are engaging in substances, that they were often introduced to the substances through with their partner, have been introduced to substances by their partner. Next point, have employment and family or social problems, right? So when we think about the connection and why we see this trend, consider the stress that comes with having employment, family, and social challenges, right? Humans in general are social creatures. We need connection. We need to feel understood. We need to feel loved. We need to feel accepted. And when that social safety is threatened, then that can cause a lot of overwhelming stress. And that can cause us to feel either anxious or depressed, and a number of different things in between, sometimes simultaneously. Having health challenges, and again, with the health problems, and the next, that correlation kind of ties right back into what we just talked about a moment ago around the stressors that come up with things, right? In addition to the way that substances impacts our organs and our systems, right? So there's a complexity that happens that shows us, that helps to explain the correlation between the health problems and the likelihood of women entering treatment. So when we think about the family history of alcohol or other drug problems, someone made a question around, what was the substance use like in your family, right? What did you observe in your family with substances? When do you find yourself using? What happens right before you use, right? There's some additional questions that can also help to understand the context and expectations around the use of alcohol and drug problems. When was alcohol most often used in front of you, right? Was it just at parties? Was it shown socially? Was it shown on a daily thing? It kind of helps to get to understand what those norms and expectations that have been modeled were as an influence to the coping style and patterns that the women may be choosing, in addition to the hereditary components of substance use. Also, seeing that they're more likely, women who use stimulants or in treatment are more likely to have a shorter period between the onset of substance use and treatment entry, right? Seeing that they're in just shorter period in comparison to men, right? That there is the, I guess, more motivation and demands that we see. And that kind of leads to the next point, where women actually are shown in some research studies to relapse less frequently than men, to be more motivated and attend more treatment sessions, right? And interestingly enough, ties right back to those specific considerations we want to think about with women, when they're seeing that women are often motivated by showing up for their children, meeting the demands of childcare, parenting, and spousehood. And so this helps to also understand the context of why we're seeing the statistics and the correlations that we're seeing when we think about women and their engagement in treatment as well as stimulant use. So let's look and understand what are stimulants, right? Because we keep throwing out this word stimulants, stimulants, stimulants. So what do we mean when we say stimulants? Stimulants are specifically a class of drugs that speed up the messages in the body, in the brain, and in the systems, right? And so it has an impact on our autonomic nervous system. It has an impact on our reproductive systems, our digestive systems, and our major organs, right? Which is some of the reasons why we'll see some of these physical challenges and impacts that can happen and dangers that can occur when using stimulants. It includes caffeine, nicotine, methamphetamines, methamphetamine. I'm not even going to try to pronounce that right now. Diet, AIDS, and cocaine. And it can come in the form of injectable liquids, tablets, capsules, powders, and small chunkier crystals, or a whiter brownish crystal like powder. And there are also, when we think about the different names that we may hear when we're speaking with our clients, rather that be adolescent clients, young adulthood, people who are women that are in young adulthood, or women that are in different communities, right? There are different names that stimulants can be called. They're very seldomly called a stimulant. And so some of the names we want to listen out for, maybe pay attention to, may include uppers, beans, pep pills, speed, dexies, smart pills, black beauties, crank, and ice. And it's looking at, different types of stimulants especially, but understanding that these are some of the code names that we'll hear, as opposed to listening for the word stimulant. So how are stimulants used, right? It can be used through smoking, snorting, or injecting. So when snorting, there's a loss of smell that can happen. It can cause a deviated septum. It may cause frequent nosebleeds or damage to the nasal cavity because of the lining of the nose being impacted. When we think about methamphetamine use, it can cause tooth decay and gum disease. Smoking can cause lung and airway damages, whereas injection or intravenous administration can increase the risk of HIV, hepatitis B or C, or other bloodborne pathogens that can be transmitted through the sharing of tools. And so when we think about women in context again, and we think about how women are often socialized to be very particular about their appearance, and how some of these impacts and risks of using and administrating in certain ways can have an impact on one's appearance, right? And how that can play into treatment, and how that can play into self-esteem, and the stressors and the challenges that come with the emotion and the mental health, or emotional health and mental health, around feeling good about oneself, right? So let's look at the effects of what stimulants are. Now that we understand that stimulants have an increase, basically speed up the body altogether, and that they can be injected, snorted, or smoked, let's look at how we can understand the effects of what stimulants do, right? I mentioned earlier when speaking on women having a shorter distance between their use and their addiction, as size, weight, and health, right? Because a size, weight, and health is going to impact the metabolization of and the absorption of the substance that we're using. Also, the frequency of use. If someone is using substances, stimulants, more frequently, then that's going to have an impact on how the body is responding, right? Similarly, if there are other drugs that are taken around the same time, that and the interactions that these drugs may have in the body, the amount of stimulants of drugs that are taking right now, in addition to when we think about all the complexities of how often are they using, what is their stature and their size and their health status, right? Because if they have health challenges, their immune system is trying to work on healing and responding and managing, and when stimulants come into play, it throws the body off whack because it increases everything, right? And then we have the strength of the stimulants and other drugs. And one of the challenges that has been demonstrated in the literature is that there is really no way to know oftentimes no way to know what components go into some of the drugs or stimulants that are being sold on the streets. And so that can have a very significant impact on someone possibly having an overdose, even though they may be using for the first time or within the first handful of times. So there's an increased danger when we see combined use with other drugs or alcohol, right? And when we think about alcohol being a depressant, whereas stimulants stimulate the nervous system, those two competing interactions with the body, right? And so it's like completely throwing everything off rack. We have driving or operating heavy machinery because of the way in which the mind is processing things quickly, the motor agitation and things that we'll see in a moment on this next slide. It also impacts, or it has an increased danger when judgment or motor coordination is required, right? When the person is alone, because if they were to overdose or have an adverse reaction and they are alone, then they are less likely to get the support that they need to recover. Comorbid mental health challenges that exist. And when we think about women, especially women who are using substances or stimulant use, there is a high comorbidity or likelihood that a woman is also experiencing mood disorders, anxiety, depression, as eating disorders as well. And so heart problems exist. This also can increase the danger, because if stimulants are increasing the heart rate and you already have heart challenges, you can imagine how that would complicate the body's health, right? And so these are the effects of stimulants. We're going to take a more in-depth look at the long-term and short-term effects, right? But first, let's take a moment to come back to the chat box and think about, I'm sorry. how we can begin asking questions again to assess these different contingencies, right? Or how we can assess the likelihood of risky behavior. So when we're thinking about the components that increase the danger of stimulant use, what are some questions we can ask to get at understanding mental health challenges, to get at understanding previous health challenges, to get at understanding the who they're around when they're using, to get an understanding anything that is going to have a higher impact on their on the risk or danger level that they're experiencing. So I'll exit the presentation once again to come out to the chat box so that we can think concretely about some language we can use to help ask questions as we're assessing the amount of danger. Because as we'll see in a moment, one of the criteria is looking at the risky behavior and the impact that can have on our the level of the severity of the substance use disorder. Okay. Just- Have you been to treatment and how do you feel about it? How are you paying for the drug of choice? How do you feel safe at home? So these are some of the questions from earlier. Right now, okay. Do you use alone or do you use in presence of your children or children? So I would recommend phrasing it as an open-ended question of who are you around when you use? Do you feel treatment has helped you? If not, why? And kind of coming back to the reason why I make that suggestion around the open-ended question of who you use, who you are around when you use, is because this allows for them to decrease the defensiveness of when we ask yes or no questions that are attached to like stigmas, especially understanding that with women, the impact of their use on their children is one of those pieces that can cause defensiveness and stigma or shame. What is your drug of choice? When and where do you usually use? Who are you with? Your drug of choice helps you understand that potty drug use, whether or not there's the increased danger of having multiple drugs in your system. Are there situations in which you are more worried about the choices you make related to your using? Great question. Do you use stimulants? Oh, we said that one already. Mhm. What are some risky behaviors you might engage in? I challenge us to think about how we can make that question into a less stigmatized question. So, kind of thinking about what are some ways your use impacts your decision making. Someone asked a question of what triggers the desire to use. Most women are not going to be honest if their kids are around. Yeah, so that's a great point. And so also thinking about how can we have the conversation outside of the presence of the children, right? Whether that be through phone, maybe that's through a written assessment, maybe that is through maybe say if a colleague can look out on the children for a couple of minutes while you do the assessment. That might be talking with your program directors about seeing if there are some grants or other organizations that they may be able to partner with where they can get assistance with healthcare or childcare. Might be some couple of ways to work around that challenge and that barrier. That's a really great point. Asking about are you aware of your triggers? That's really great question around thinking about the frequency, the duration, and the intensity of like how much they're using, right? Is there anything or anyone in the home that could be a potential harm? What are some situations or triggers that cause you to want to use? Tell me what you know and what you've heard about drug treatment and recovery. That's a really great question to kind of help assess their readiness, to help assess their motivation, and also any concerns that they may have about what to expect. And when we think about trauma informed care, one of the things we want to do is make things predictable. So after hearing their response, addressing their concerns, but then also helping them to understand what to expect, what the program might be like, the length of the program, talking about what the intake process may look like, etc., can also be helpful in creating that predictability and helping people get to that next step. What places did you frequent that remind you of your use? Do you know your triggers? What are your symptoms when you use drugs? What are your triggers? Do you use while doing childcare? That direct line of questioning will likely get a defensive no. So again, kind of just coming back around to what maybe who's around when you use, when at what point during the day are you typically high, right? Because then you can kind of correlate between the children being present or not present. Where are the children when you're high? Maybe another way to also kind of help reduce the stigma and the defensiveness around what can happen, the potential consequences and judgment that women that often anticipate when we are talking about substance use and parenting. And I mean, parenting is, sensitive topic for anybody, parents, rather they be fathers or mothers. Do you use the same amount each time? What causes you to use more or less? Really great question. What are you experiencing before using a substance? I'm concerned for you. Who knows that you use, and how often do they check on you? Okay. How would you describe your physical health? Any particular health problems now or when you were a child? Has anyone you loved ever shared concerns about your use? What thoughts and or feelings do you experience that accompany the desire to use? These are some really great questions that speak to the assessment piece of like even just understanding the level of use. We'll look at criteria in just a moment. What are other alternatives you have tried before stimulant use? That also helps you understand that polydrug use component, as well as whether or not they may have more than one drug of choice. What kind of changes have you noticed within yourself since you've become involved with drug use or within your life or relationships? Good question. What other, it's open-ended, right? What other ways did you try to cope with triggers? What's going on when you feel most tempted to use? What changes would you see within your life if you were no longer involved with drug use? Really great question to kind of help lead into motivation. And what have been the benefits of substance use, right? Helping to understand the function behind the behavior, right? And the purpose behind the behavior. Understanding that it might be to cope with those demands on relationships. It might be to cope with their trauma and a number of different things. That's a really great question, because then it also helps in the treatment process, around the linkage of resource process, how we can begin to provide the support that they need. It says, are you using more than one drug? I would encourage an open-ended question of, when do you use more than one drug? And that way, if it's like, in a way, making it so that it's minimizing the stigma around yes or no question, right? So that I can say I don't, or I can give a number. Right. So kind of thinking about when we're kind of doing some of these more assessment-based questions around the use, and that are kind of stigmatized and may end up bringing up some defensiveness, which is something we kind of think about as social safety threats, then we want to try to use open-ended questions so that we are feeling it feels a less judgmental, decreases the defensiveness, and also increases the likelihood of the self-report being more accurate. And when is it that you don't use? That's a great question as well. These are all amazing questions that we have coming up, that we've asked and come up with. And so I'm going to continue as we look a little bit at a deeper understanding of like the different dosages and the impacts of stimulant use and what that looks like. So when we have lower dosages of use, it can cause anxiety. Again, thinking about it being an upper, and that automatic nervous system around the sympathetic branch actually being activated and causing a lot more anxiety. That can be symptoms of, your heart rate being increased. It can be symptoms of being really preoccupied with things, intrusive memories. It can be restlessness. We have euphoria, being on like cloud nine, feeling like really, really great, on top of the world. We have heightened feelings of well-being, increased heart rate. And I'll just stop here at the euphoria and heightened feelings of well-being, because when we think about the context of women, and we think about the relationships, the demands on relationships, the experiences of trauma, and the comorbidity between depression, there are often times, right, when there may be a low feeling. I don't feel good about myself. I'm feeling really helpless or hopeless. Maybe I'm having suicidal ideation. So these euphoria and heightened feelings of well-being may be something that's desirable, right? And this is the means in which stimulant use may be the means in which they're reaching those goals of having an opposite of this distressing experience of hypoaroused experiences. We also see increased heart rate, increased blood pressure, increased alertness, talkativeness, and a reduction in appetite. And these all can be explained by that activation of the sympathetic nervous system, which is what stimulants are impacting. And that sympathetic nervous system is responsible for all of our major systems in our bodies when we think about our temperatures and our reproductive systems and our heart systems and our breathing respiratory systems, etc. Now, higher dosages, right, can also include anxiety, but it can include tension, it can include increased body temperature, nausea, tremors, seizures, coma, and death. And that is because of the higher the dosage, right, the more stimulants rushing and flooding your body, the more likely that that sympathetic branch is being activated at a high level, causing more intense reactions in your physiology. So potty drug use is something we want to be mindful of because oftentimes substance use is not a single drug of choice. Oftentimes it is accompanied with other drugs as well. And so when we think about the different categories of drugs and how they can impact the body, we'll talk a little bit about what this looks like because it's important for us to be mindful of these things so that as we're engaging clients or women who are experiencing these things, we're able to provide them with psychoeducation and information about the impacts of drugs on their bodies, right? On their moods and thoughts. So looking at amphetamines and some antidepressants, we have elevated blood pressure, possibly leading to an irregular heartbeat, heart failure, and stroke, right? We have similarly alcohol, cannabis, benzos, and amphetamines in combination could cause the body to go in a distress because of the conflicting effects, leading to an overdose, or the overdose being the shutdown of the body. We have ice speed or ecstasy being used together, can cause a large strain on your heart and other parts of the body, which can also lead to a stroke, which is essentially all the organs kind of like overworking all at once. We have the ice, alcohol, cannabis, and benzos that can cause a large strain in the body as well, that can also lead to an overdose in addition to masking the effects of depressant drugs, which increases the likelihood of an overdose. Again, because of the depressants being the parasympathetic branch, the stimulants being the sympathetic branch, and those competing energies, if you will, that are happening in the body, just going into an overload, trying to correct the problem, but not able to because of it also still trying to process all the stimulants and drugs and everything else that's impacting it. And so it just kind of throws the natural system of the body's self-healing and corrective piece off a bit, and why it can become very dangerous for us. Another important point is to understand that as of late, there's been a significant increase in the comorbidity of fentanyl and stimulant overdoses. And so that's something for us to be mindful of as well. Okay, so then here we have our short-term impact, right? It can cause fatigue, overwhelm, right? Because if you kind of think about like, what goes up must come down, or all the energy that is expended in stimulants, naturally your body will get tired, right? Especially if the frequency and the duration of being high is long periods of time, which can likely potentially cause another urge to go and use to get rid of that fatigue, right? We saw in the earlier slide that one of the reasons was for an increase in energy, that a common reason for women to use was because of a desire for the increase in energy to meet the demands of life, to meet and balance the depressive symptoms and mood disorder symptomology that occurs. We have depression, chronic insomnia, increased appetite, impaired memory, the inability to feel pleasure. So let's just say pleasure. The endohedonia is a clinical term, and that is talking about not being able to engage in activities that felt good, right? So maybe my child is making a milestone, I'm not excited about it, or I'm engaging in an activity that I've loved before and I'm not able to feel the pleasure that I once felt. And so did you see some of these are some depressive like symptoms, but depression in and of itself is a cluster of symptoms, whereas some of these are may be a part of depression but are teased out as well as potential impacts of the use. We have accelerated heart rates, right? We think again that sympathetic system being activated with stimulants being upper, mental health challenges can pop up, psychosis, aggression, hostility, amongst many other challenges that happen, in addition to elevated body temperatures. Again, this is all because of the sympathetic branch being activated and working on overdrive. And when we think about the impact of trauma on our sympathetic and just our autonomic nervous system in general, there is this there's a significant potential exacerbation of symptomology, in addition to our masking of symptomology as well. And so one of the things we want to consider for our women that we're engaging with is, when did the symptoms begin? Did it begin before your use? Did it begin after your use? Did it begin during your use? Has it intensified since you began using, right? Or how has it changed since you began using, when we think about it being more of an open-ended question, because there is a significant overlap between trauma, mental health, and the impact of stimulants on our nervous system. Now, when we look at our short term, let's take a peek at our long term impacts of stimulants, right? So we have persistent hypertension. So we saw that in short term impact and in general, stimulants will increase our blood rate and our blood pressure. And so persistent hypertension, because of the consistency and the frequency of stimulant use and long term impact, can cause our bodies to kind of go into a state of hypertension. Similarly, it can cause the cardiovascular complications, such as heart disease, stroke, increased risk for heart attack. It can alter our brain structure, because our brain is a very, very malleable creature. And so in the attempt to regulate all of those overdrive of endorphins and hormones that are happening in the brain, it will begin to essentially create fewer of those on a natural basis in order to try to offset it, right? Which can kind of increase and contribute to our withdrawal symptoms at a later time. The impaired cognitive, neurological, and emotional systems can also be impacted. And so when we think about how we're thinking, are we having helpless like thoughts? Are we having suicidal ideation? Are we having flashbacks and memories pop into our minds? Neurologically, are there seizures occurring? Are there misfirings happening in our brain, again because of that altered brain structure? Or the emotional systems, where the stimulants can intensify, right, or shift, or even impact and cause, as we'll see in the next point, there are mood fluctuations as well. And then we have decreased attention, with the idea that stimulants being, our brains being hyperactive and overactive, is very hard to pay attention to one thing at a time, as well as confusion, because of the impact of memory, when we're thinking about the activation of the sympathetic branch of stimulants that stimulants used to do. They also can cause impaired memories, impaired impulse control, reduce motor skills. It can weaken the immune system, as well as increase our susceptibility to retroviral replication, or essentially being sick, which is kind of contributing or explaining further our weakened immune system that we're thinking about. And again, the reason being that our nervous system is being impacted when we're using stimulant use, and our nervous system is responsible for our functioning and our health. And so that's why when we have this long-term increased frequency and duration of use, we see more significant impacts across health and across our abilities and functionality. Okay, so before we go on, let's then come back over to the chat box and think about how we can provide information in a compassionate way to participants or women who are using or abusing stimulants around the impacts of use, right? Helping them to make sense of their symptoms and what they are experiencing. All right, so let's see. That would be another good training, Tony. Our the looking at cannabis and how people are using that to self-medicate as well as in a diagnosed manner. So we have here, how do you feel when you are not able to use your doctor? Okay, so getting an understanding of what their symptomology looks like, right? Like what are some of the things that you're experiencing in your body, drug of choice. And so to kind of remind us in this, when we think about the impacts on fatigue and depression and chronic insomnia, we're not, in addition to assessing those things happening, how do we also help connect and understanding for our clients that the use of stimulants has an impact on the symptoms that you're describing? What do you feel that the drugs help treat for you? How are the drugs helpful? To already have information cards in your office so it's readily available, great, great, great idea. For those of us that are maybe doing like substance use treatment or outpatient, like mental health based settings, you might have little psychoeducation cards that you can incorporate into games or into discussion components, little videos. Who is your support system when you experience symptoms? How do your family and friends feel about your drug use to establish stage of change? hmm hmm Assessing their stage of change through understanding whether they're how it's impacting their relationships and if they are acknowledging it or dismissing it. Makes sense, Rose. And so when we're thinking about how we connect this information of the different use to our clients, we can do it by connecting it to their experiences. You described earlier that you're experiencing some heart pains and some anxiety. Those can be some common responses to using stimulants, right? Or providing some education around how stimulants impacts the body in general. I mentioned videos may be one way to use them in addition to asking like showing them maybe a chart or a list of them and asking, have you experienced any of these? And then providing information from a spring point from there. Tell me how your body feels when you're sober and have to remain sober at that time. Providing resources to the impacts of stimulants. Yes. And so we'll have lots of resources for yourselves as professionals in just a moment. But again, it's going to be important in all treatment processes is empowering the participants with information around their choices are impacting their bodies and how impacting their symptoms, or maybe exacerbating their symptoms if they already had trauma and mental health challenges that pre-existed. So I'm going to continue, and the next thing we'll do is take a peek at the stimulant use disorder. It's 11 o'clock. Actually, why don't we take a moment here and let's take a 5-minute break. And after
we can all meet back here at 11:07.
Okay, sounds perfect. And then back up, if that's okay, I'll try to get on with another computer to see if we can get that working.
It's up to you, Elle. This is working for me. If it's working for you, I think it's okay. It's just up to you completely.
Okay. We'll just stay here then. No need.
Perfect.
Hey,
All right. Well, we'll
everybody,
see everyone back at 11:07. Get some water, stretch your legs. See you all back then. Thank you all for joining us. We are back from break. Elle, I will let you go ahead and keep going. And everyone, welcome back to today's presentation. We're going right now.
Awesome. Welcome back, everyone. I hope you are feeling better after taking a moment to stretch, get some water, or do whatever it was you needed to do. So what we have reviewed so far is looking at the specific gender considerations that we want to think about when we're looking and working with women who are using stimulants, specifically thinking about relationships, thinking about trauma, thinking about parenting and pregnancy, and how we are utilizing the understanding of the intricacies of those components in our assessment, in our engagement, and in the service provision or programming that we're providing. We then began looking at the prevalence and the understanding of what stimulants are, the short-term and long-term effects. So now we're going to look at what is the criteria to meet stimulant use disorder, what that actually looks like, and then we'll go into the evidence-based practices for treating stimulant use disorder and what different settings they can be used in and what literature there is or research there is to support their effectiveness. I guess right after our community impact. So real briefly, obviously we talked about the short and long-term impact on the individual, but substance use does have an impact on the community. It can have negative outcomes for the children due to the unpredictability that can arise with substance use, due to the changes in behavior and personality and moods, etc., and how that impacts the attachment and engagement with children. It can also cause a heightened crime in different communities or in communities due to the urges needing to be met depending on which stimulants that are being used. Different ones have different rates of intensity in the addiction. We have costs that are associated with the enforcement and incarceration of stimulant use, in addition to the environmental damage, especially when we're thinking about the toxins that come from methamphetamine labs, premature deaths that happen, costing $2.17 billion in 2015 just to methamphetamines alone. Also looking at the methamphetamine users are more likely to engage in domestic violence, commit property crimes than those that are misusing other drugs, and looking at how powder cocaine, crack cocaine, and other related offenses accounted for 75% of all federally sentenced drug offenses, right? And so seeing that stimulant use can have a very significant impact on behavior and how that can have an impact on the community, families, children, etc. So what does stimulant use disorder look like? There's an occurrence of two or more of these different symptomologies that we're going to go through that occurs over a 12-month period. So for starters, we look at taking more stimulants than intended. So when we looked at questions earlier today, there were several questions that were asked about how often are they using, when are they using, how much are they using, when do they know to stop, right? Might be another question answered. How do you know when to stop using stimulants or when to stop using? Maybe another example. Or when have you used more than you wanted to use, right? Again, that open-ended question where it's reducing the likelihood of the defensiveness of no, right, and giving them the opportunity to answer truthfully, or at least to provide that it has happened. Failing to cut down or control the use despite wanting to do so. So this might look like someone expressing that, I don't like how it's impacting me and my children, or maybe my mom or my family are telling me that they're concerned and I want to stop. But I went and bought some the other day, but I'm still using. So you might hear some dissonance in their desires versus their actions. Spending excessive amounts of time in activities surrounding stimulant use. So this might look like waiting for hours for their provider to get the use to them. This might look like waiting excessive amount of times, or spending excessive amount of time using or being in spaces that are where they do find themselves using stimulants. Experiencing urges and cravings for stimulants is also another criteria, or can be a criteria. Remember, it can be two or more of any of these, and there's a couple more on the next slide. So an urge might look like, you might ask, like, when do you want to use? How does it look when your body's telling you it's time to use, right? Failing to meet the obligations of home, work, or school. So that might be, I was high and I lost track of time. That might be, I had intentions on doing it. Maybe I started to do it and didn't finish it. Maybe so just failing to meet whatever the obligations may look like. And so we want to understand, in addition to some of those questions you all looked at earlier, was what does your day-to-day demands look like, right? And how are you getting those things done? How do you manage all of your day-to-day? What does your routine look like? How is your routine impacted by your substance use? Continuing to take stimulants, even if it has led to a relationship or social problems, right? So this may be where your family members no longer trust you because you're stealing from them or lying to them, or are the mood shifts that are causing aggression may make people feel unsafe, and they're having an impact on people, allowing you to be in their home or be around their children, right? And in spite of that, we might still continue, our participants might continue to still use. We have giving up or reducing important recreational, social, or work-related activities because of the use. So this might look like, okay, well, I was going to go to work, but I didn't because I was high. This might look like, a friend inviting someone to do something that they love doing together for years, and the participants saying no, they'd rather go and get high instead, kind of essentially choosing to get high over doing the things that have once brought them some type of joy, structure, and enjoyment. Other four symptoms are using stimulants in situations where it is physically hazardous. So this might be, doing so like on a L stop. Wait, we are in Florida. You don't have L's. Doing so like in a situation where it's not safe because of machinery. Maybe while at work. It might look like doing so while driving, right? It can look like doing so when you need complete concentration unless hazards may happen, like sewing, for instance. And so if there's a situation that's physically hazardous where my body can somehow be hurt because of my use, or someone else can potentially be hurt because of my use and because of potential symptomology that comes from that. We have continuing to use stimulants even if there's an awareness that it's causing or worsening a physical or psychological problem, right? So sometimes this looks like having maybe some lung challenges being exacerbated or started, and or maybe this looks like stimulant induced or substance induced psychosis or other mental health challenges, and understanding that there's a link there or that is worsening these things, and continuing to decide or continuing to use and have challenges with stopping even though they may have expressed the motivation to stop, right? Experiencing an increase in tolerance to stimulants, and so this looks like your body trying to adjust to it, and so I need more to get high than I used to, right? So perhaps the rule used to be I would only take a half a pill, and now I am doing 2 pills at a sitting, or I use, so it just looks like a change in the amounts that were being taken and then the amounts that it took to get the same impact that it once did. And then lastly, having some withdrawal symptoms when the stimulant is not taken, and we'll look at those in just a moment. So if a person has 2 to 3 of these symptoms listed on this slide and the previous slide, it's considered to be a mild stimulant use disorder. If they have 4 to 5 of these symptoms, it's considered to be a moderate stimulant use disorder. And if there are 6 or more of these symptoms, then it's considered to be a severe stimulant use disorder. And so recently the criteria has shifted about within the last 10 years or so. The way that substance use disorders are classified has come down to the severity levels based off of the number of symptoms that are being experienced within the symptomology. So what do these withdrawal symptoms look like, especially given that that may be one of the criteria that is being met for those of us working in mental health, or those of us working in substance treatment centers, or for those of us who just want to be able to recognize the challenges that are arising with the participants you're working with. So it may look like anxiousness, sadness, agitation, or intense cravings, right? And so when we think about coming down from your sympathetic system being activated and having all that high energy, it can cause your body to still kind of be in an anxious state. It can cause a severe crash. It can cause some like agitation and irritability because of the your body trying to find an equilibrium, and it can cause intense cravings because your body is seeking to have that high again that is now losing. Over time, it may look like mental and physical exhaustion. It may look like insomnia, depressive symptoms, right? The depressive symptoms are found to look like have a higher comorbidity and last longer with methamphetamine usage. There's also an increase in symptoms that are lasting 96 hours to multiple weeks, right? And so helping clients to understand that depending on how frequently and how long you've been using, these symptoms, any of these symptoms can exist from anywhere between 96 hours to multiple weeks, right? When we think about the impact of the effects of the stimulants in our earlier slide, remembering that weight, health, size, and usage all kind of influence how long we're going to be experiencing symptomology and the effects of stimulants. All right, so let's get into looking at the evidence-based practices for stimulant use disorder. So we're looking at a study through SAMHSA where they basically did a very comprehensive and like a literature review, essentially, looking to see what were the evidences that supported the effectiveness around treating substance use disorder. And so the criteria they had was that it had to have a very comprehensive and multi-pronged study. And by doing so, that study program or study structure allows for them to make sure that they are controlling for variables that can contribute to the statistics and that they can be explained, and it's more likely to be able to have that causal effect that we'll talk about on this next slide. The evidence also was based off of literature review as well as consultation with experts who are in the field. So looking at how do we think about the pragmatism of practice, right? What the literature says as well as what's happening in practice. So the criteria for the literature was for there to be a clearly defined and replicable study to address stimulant misuse as the primary outcome, for there to be the practice to currently be in use, or the theory, for there to be evidence of the effectiveness, for there to have accessibility of resources for implementation, and fidelity. Fidelity being the consistency in the way that things are being ran, so that we can dictate and determine with confidence that what is happening is because of the model and not because of different variances with the way that people are implementing the program. Additionally, it had a specific design, looking at randomized or quasi-experimental designs, because these are considered to be the best type of designs that give us the most casual impact, and that it's easiest to determine some of the what we call controllable and non-controllable variables, so that we're able to tease apart and have some confidence in our determination with correlation or causality. So this particular study looked at causal impact, where they actually seen that the evidence did show that there was a cause that is responsible for the outcome being measured, specifically stimulant usage, a difference in the stimulant usage. So they categorized the studies into 3 categories: strong, moderate, and emerging. And the 4 that we're going to review today are all strong evidence, where there was at least 2 or more strong research studies that had causal impact being implemented in their study. Won't get into the logistics of all those stats and stuff. It's not fun. All right. So what was the overview? Just in general, we looked at 4 evidence-based practices that we're going to walk through in a moment, which was motivational interviewing, contingency management, community reinforcement approach, and cognitive behavioral therapy. It's going to take a drink of water. The outcomes that were found, that overall all 4 of these had a reduced use of stimulants. There was a reduction in risky behavior while under the influence of stimulants, and there was also a reduction in mental health symptoms while under the influence of stimulants. So let's look at the settings and the services were delivered. They were delivered by trained clinical staff, including clinicians, as well as primary care physicians, research staff, and peers. Then the different settings across the board: walk-in clinics, urban trauma centers, university and private run health clinics, community-based clinics, and even virtual programming. And so there was a wide range of settings, a wide range of practitioners who were using the study modalities or the evidence-based practices. So we'll take first a look at motivational interviewing as our first evidence-based practice. And what they found is that motivational interviewing had strong evidence, and motivational interviewing has a particular goal to overcome to help the participant overcome any ambivalence around their feelings or insecurities that prohibits their motivation or impacts their motivation in a negative way. And so we want to help process those emotions, process those insecurities, so that we see an increase in their desire to be, and their motivation, and their ability to change or reduce or stop the stimulant use. And so there are 5 principles that are underlying the process of an interaction with clients. And motivational interviewing is a model that is very, very helpful in engaging our clients and building rapport with our clients, and also in creating trust with our clients. And some of the principles include the expression of empathy through reflective listening. So reflective listening being we are acknowledging what the individual has said to us, right? The underlying values, feelings, concerns that are happening, right? We're listening not only to their words, but also observing their body language, right? We're doing some active listening within that process. We're summarizing things, and motivational interviewing kind of breaks down different ways that you can deliver reflective listening. And at the end here of this presentation, there are some resources for you to get additional training on each one of these particular models. Some free and some paid. We have identification of the discrepancies between the client's goals and values and their current behavior around usage, right? And so you don't want to use because you don't like the impact that it has on your ability to complete your household chores. And last week you found yourself high and it made it hard to keep up with those chores, right? And so we're reflecting what they're saying to us in those discrepancies, or maybe helping guide our clients through open-ended questions around how did your substance use impact your goal? How did it help you meet your goal? How did it challenge your goal, right? Maybe some ways to help identify discrepancies in a way that, to the point 3, avoids arguments and direct confrontations, right? When we think about substance use disorder, the old school model was very confrontational, very confrontational and authoritative. And especially when we're thinking about working with women and the relational context and the importance of relationships when we're thinking about gender specific treatment with women, it's very important for us to be mindful around how arguments and direct confrontations will impact the professional client relationship, and how that ultimately will impact the client's motivation and follow through with services, right? And when we think about trauma informed care, it compromises social safety in addition to other areas of safety. When we think about number 4, we're adjusting to the client's resistance rather than opposing it directly, right? And so this may look like us maybe pointing out a discrepancy or making a suggestion, or helping them to walk through their pre-contemplation stage to the contemplation stage, or essentially where they're not considering being stopping use versus actually thinking about the benefits of stopping use. We're going to adjust, meaning that we're going to lean into the resistance and work with the resistance rather than shaming them about the resistance, or using like scare tactics and imposing it in ways that again is compromising their social safety or the relationship in the process. Number 5 is to support self-efficacy and optimism. So when we think about working with women who have experienced stimulants, we want to be very, very intentional about helping them feel confident that they are capable of stopping, that they are capable of using the skills, that they are capable of overcoming whatever barriers that has prevented them from successfully titrating, if it's a harm reduction model, or stopping altogether. And then the optimism is really about strength, kind of thinking about a strength-based approach where you're looking at how do you engage, how do you affirm their progress, affirm their intentions, affirm their, excuse me, affirm not progress intentions, their values, right? In addition, in ways to help continue to motivate them and positively reinforce the process, because the shame and the guilt and the stigma that comes with substance use disorder is very heavy. And so in the process of treatment or engaging people who are using, we want to make sure that we are creating a safe relational context with our clients or with the participants, so that we are able to do so in a way that is helpful and that does not also then frustrate ourselves as professionals because we're not seeing the results we expect. So logistically, they found that their typical settings for motivational interviewing included a wide range of healthcare settings, from primary health clinics to general specialized hospitals, right? So I'm gonna drink some more water. The studies looked at participants who were both male, female, non-binary, various races, ages, and ethnicities. And the practitioners who delivered motivational interviewing included primary care and behavioral health professionals, peer providers, and criminal justice personnel. And that there were additional trainings, and just so you all know that there's training available for clinicians, non-clinician peers, and those who have no training in counseling or therapy. And so this motivational interviewing, this theory has been around for a number of time and has originally originated in the process of treating substance use, but has become much more widely used across the board. So the process, how often is it happening? What does it look like? There is no particular prescribed time period. It can range from a single 15-minute session to a multiple hour long session. And there's no generalizable evidence about the length or number of sessions that we want to have in order to reduce use. But we do know that the outcomes, we see that there is a reduction in the number of days of stimulant use and the reduction in the amount of stimulant used per day. And so when we think about the amount used per day and how many days, that also kind of feeds back into the criteria around how often, the frequency of use, how many days out of the week do you use stimulants, right? Kind of helps to get an understanding around that frequency as well. Or what does a typical day look like with use? So the next model is called contingency management overview, where the goal is to use a form of operant conditioning, which is behavioral change through reinforcement of the desired behaviors using cash, prizes, or privileges. So we're incentivizing the behaviors, right? Some examples included incentivizing attendance of treatment sessions, the adherence to prescribed medications for other health conditions, using stimulant negative or having stimulant negative urine samples, excuse me, are giving out vouchers for redemption of retail goods and services, and providing opportunities to win a prize or cash payments. So while the structure does look different with across programs, there's typically two different approaches that are used. One is called the fishbowl and one is called the voucher based. So the fishbowl method is where a client will draw a token from a fishbowl for a chance to win a prize, whereas the voucher based reinforcement is where the vouchers are earned for the particular behavior that is being encouraged in the program. So for a second, I'd like to bring us over to our chat box as we think about what are some other examples of incentives that we can use in a contingency management program. Some examples of incentives that we can use when we're thinking about contingency management. And so while we think about that, there was a really great point. It says a person from another country told me in his culture, it's polite to ask before making an observation or that discrepancy. He said if the person doesn't like it, you remind them that you did ask permission to notice or observe that discrepancy and then reaffirm that you're not judging them, just taking an interest. I think that's a really great point, Kelly, and I thank you for making that point. I think it reminds me of trauma-informed care around asking permission before we provide feedback in general, right? Kind of helping to lighten the load and letting them know I'm not here judging you. I'm actually just wanting to provide some feedback to maybe support you. Right. So contingency management. We have a participant who works in a drug court and they use contingency management. Clients spin a wheel and get snacks or treats or get to leave court early. It's surprisingly effective and garners a lot of pride. That's awesome. Look, food is a great way to incentivize humans in general, right? I mean, leaving court, who wants to sit in court all day? So those are some really great incentives. In the residential program, we have longer phone calls and visitation, certainly, right? Especially when we think about how having contact with their support system and their community is going to help increase their recovery and their symptomology, right, and their resiliency. It says at the hospital we were used to going out to the canteen to get food. Nice, being able to leave. That's the hospital setting, yes. Health fitness pass for a day or a month, great. Movie passes or other goods, yes. I've seen bus tickets. When I worked in substance use, one of the things we did in the methadone clinic was provide bus passes to individuals who attended their sessions. I think they would get like 3 per every group or individual session they made. Are there any other examples? This is a target case manager. When I visit children, I let them pick a treat at the end of the visit as long as they participate. Visitation with their children, yes. Video phone calls to see their family through the computer, yes. Awesome. So just thinking about women relationships, there are a lot of relational components that are being exemplified here in the incentivization, which is great because when we think about women, the relationships that they have is very, very important. I mean, with humans in general, but especially when we're considering gender specific treatment with women. We used to give the opportunity to visit the art therapy center or the pool. Nice. In a 28-day substance abuse program, we have a point system, and if they get 100% for the week, they get to pick a prize out of a grab bag. Yeah, nice. Gift card for a coffee house. Yeah, so there are so many number of ways that we can incentivize the programs, right? And then for those of us in like nonprofit settings with like lower budgets, there's ways to maybe position or think about talking with larger organizations and companies that can get a write-off for donating certain things to your program to be able to offer as particular incentives. Thank you everyone for your participation. If it's okay with you, I'm going to continue looking at the logistics of contingency management. So the typical settings that they found in their research review was healthcare settings, including a wide range of healthcare settings, including some virtual settings. They looked at, again, demographics across genders, ages, races, ethnicities, individual and group settings. Now, the practitioners were primary care physicians, behavioral health professionals, and criminal justice personnel. And there was training or coursework in behavioral analysis that helped to support the intervention or the use of the intervention, right? So when we're thinking about how to motivate, how to understand the function of the behavior and pieces like that, that is additional technical training that can be helpful in being and giving that fidelity that was mentioned earlier about a need for the model to be included in this research study here or listed as one of our evidence-based models. The process is similar to the motivational interviewing. There's no prescribed time. Oftentimes, contingency management process can be combined with other therapies, which is really cool because it's one of those that can be married to an existing program, right? And added into as another component. And it's typically a 12-week schedule and uses drug screenings 2 to 3 times a week. The outcomes that were found for contingency management programs were reduction in the number of days of stimulant use, reduction in stimulant cravings, reductions in new stimulant use, and reduction in HIV risky behaviors. Okay, so our third model is community reinforcement, the community reinforcement approach. The community reinforcement approach, the model, its goal is to identify the behaviors that reinforce stimulant use, right? And so when we're thinking about all behavior has a function, meaning all behavior has a purpose. So we're specifically with community reinforcement looking at what is reinforcing the use of stimulants so that we can, and then helping them to make a plan for an understanding of how a substance-free lifestyle will be more rewarding than the one that includes drugs and alcohol. So through understanding what is reinforcing the stimulant use, you're able to then help them identify different behaviors and or activities, environments, etc., that help get that same function met, right? Maybe it's thoughts, depending on the reasons that people are using, we can help them get those needs met in a process through sublimation, which is when we change over our behavior and urges in a way that's more quote unquote acceptable. We have participants then being encouraged to take substantial behavioral changes. We want them to engage in new recreational activities and develop new social networks. Why? Because when we look at the behavioral changes, especially when we're thinking about stimulant use, is very important to have the structure and support to be included in the behavioral change to help enhance the behavior change. Because what happens with our brains is that our brains are very habitual. And so if I am used to getting high in this particular place or used to getting high with these particular people, then when I'm with those people or in those places, my brain is more likely to activate an urge to use. And so by engaging in new recreational activities, we're getting those endorphins or dopamines and those happy hormones kind of being fired and engaged in that are similar to the same things that kind of happen when we're experiencing stimulant use or using under the influence of stimulants. And then we also will see the social networks helping to enforce that coping, right? When we're thinking about women and how that can help to manage the demands on life, how that can help to manage, get their support systems where they're receiving support and seeing, being heard, feeling known, but it also can help to build resilience from their experiences, whether that be present, current, or present or current traumas, in addition to anything that may develop in the future, because the human interaction is so invaluable, just so invaluable to all these treatment processes that we're thinking about when we're thinking about how do we help humanity heal as a whole. So it's commonly used in conjunction with contingency management, which is the reinforcement process or incentivization model that we just looked at prior to. There are multiple elements that happen here. I'm going to mute just so I can cough. The multiple elements include analyzing the client's substance use, right? So when we think about all those questions you all came up with earlier today, kind of understanding the nuances behind why they use, when they use, where they use, how they use, is really going to be helpful in understanding the client's substance use, so that not only we understand that excuse me, that functional piece around why the substance use is existing, so that we can really begin to help our clients also understand their triggers, also begin to understand the different coping skills and things that they can use to help address and manage the triggers that come up and that address the functions and the desired outcomes of their substance use. So then we have relationship counseling. Where we're again thinking about women, right, and how important relationships are. And so the relationship counseling is in looking at how do we not only engage others, like their support systems within the process, but then and kind of help facilitate the skills for interpersonal and a personal effectiveness, right? Because as we saw earlier today with women, one of the pieces that can contribute to substance use is the demands or challenges within relationships. And we also saw that it can furthermore create problems within the relationships, right? So how do we then also repair the relationships that have been harmed through the substance use? Vocational guidance, when we think about how a lot of the women who are entering treatment are often younger, underemployed, unemployed, lower education levels, etc., providing vocational guidance assists them in getting the skills that they need to be able to have some structure in their life and feel good about themselves, their contributions, their ability to take care of themselves and meet the demands of life, whether that be financial or materialistic. Or even passion wise, right? Especially if we can get them into a vocation that speaks to their inborn hobbies, passions, or skills. Similar to vocational guidance is job skills training. And then last, we have the building social and drug refusal skills, right? Because naturally, everyone is not always capable of completely avoiding certain people that they use with or completely avoiding opportunities to use. So how do we help them to manage what that looks like? This is especially important when we're thinking about working with teenagers. Right, I know earlier, quite a few of us are working with adolescents and teenagers, and so helping them to find, cool, socially acceptable ways to bow out of use or to redirect the attention or question from their peers. When we look at the typical settings, we have inpatient settings, home visit programming, as well as the community, the reinforcement contingency management program that we talked about with the incentives and vouchers. There's typically a weekly appointment in the outpatient settings, and with family training version, there's an option to enhance client engagement through a concerned significant other. Again, just highlighting how important engaging family and support systems are in general for humanity and healing, but especially for women, when we think about how important relations and interpersonal relationships are to their day-to-day functioning, as well as their well-being and their wellness. So we have the demographics of those who participated in this program and in these studies. It was across ages, genders, races, and ethnicities, in both individual and group settings. And there is an adolescent version of the program for those of us who work with teenagers specifically, and as opposed to those who are working primarily with adults or those who works with lifespan. I saw earlier that some of us work with people across the lifespan, youth and adults. So the type of practitioners or professionals that were or that use this and have used this model of community reinforcement approach are those who have strong fundamental counseling skills such as supportiveness, empathy, and a caring attitude, right? Most people who go into the helping field naturally have empathy, a caring attitude, and supportiveness. However, with the challenges that come within the field of social services, the demands on top of just life as an adult in general, and all of the demands that we have outside of profession, it can easily become impacted when we're not aware of our own stress responses, when we're experiencing burnout, compassion fatigue, and vicarious trauma. And so it's important that we're mindful of and assessing how we're showing up with our clients, right? Because in order to successfully engage a client in any programming, especially something as sensitive as substance use, we definitely have to have a safe relationship for the client to participate in. There were primary care and behavioral health professionals, as well as some pharmacists. It does require a directive, energetic, and engaging person. And there is a manual that outlines a procedure. And it's called a community reinforcement plus vouchers approach. And so this manual can help to guide the process of utilizing the community reinforcement approach. Looking at the intensity, duration, and outcomes, the Community Reinforcement Plus Vouchers Approach Manual does recommend a 24-week treatment program that meets once or twice a week and submits 2 to 3 urine samples a week. The outcomes for the use of the community reinforcement approach included reductions in cocaine abstinence, reduction in addiction severity, and reduction in drug use, specifically the number of weeks used, the frequency of use, and the amount of time spent on use. Okay, so I want to pause just for a moment to see if there are any questions. I'm going to come out real quickly. Escape, come over to the chat box to see if there are any questions before we go through the fourth and final evidence-based practice for stimulant use disorder. Okay, so it looks like there are no questions, but there is a good point around being mindful about the reward of family contact and how that, or what incentives can feel not coercive, but authoritative, right? Or make them feel like they have to be earned. Sounds like you are getting, yeah, I am. Thank you. I'm sorry if I happen to pause in order to like cough and not cough in your ears. Okay, that manual actually have it linked in just a moment. So I'm going to go back to the slide or the slides and share the resources after sharing this fourth and final evidence-based practice for cognitive behavioral therapy. So we've all more than likely heard of CBT, or cognitive behavioral therapy. And the goal of cognitive behavioral therapy is to help the client understand their current problems, the challenges and experiences in order to help them change the behaviors and patterns of thinking. So the idea is that there is a direct connection between the thoughts, the behaviors, and the actions that show up based off of different situations that we experience as humans. And so cognitive behavioral therapy is short-term and goal-oriented. It's a process where participants develop an accurate assessment of their circumstances and emotions to help guide development of realistic strategies. And so when we think about what does accurate assessment look like, because that word sounds kind of like judgmental, we're thinking about understanding whether or not the cognition or the thoughts that are present are helpful, if they are realistic, or if they are catastrophic, and how they are impacting the emotions and behaviors of the participants. The third piece is that it addresses depressive cognitions or thoughts and other distortions that are associated with depression, anxiety, and substance use disorders. This is really important because, again, when we think about substance treatment and stimulant treatment with women, there is oftentimes a comorbidity between mood disorders, depression, anxiety, and substance use disorders, right? And so understanding that thoughts have a fueling to some of the behaviors of specific substance use, or engaging in risky behaviors, etc., or managing intense emotions, depending on where we fall in that cognitive behavioral triangle, Addressing these cognitions is really going to be helpful, especially if stimulant use isn't the function behind the stimulant use is to manage depressive symptoms, right? Or to manage other symptomology that it's like low energy, low more innovation, more low motivation, etc. So it also looks at cognitive evaluation in the context of stimulant use. So we're evaluating those thinking patterns that are unhelpful. We're evaluating behavioral patterns that follow the thinking patterns and negative feelings that come as well. And so again, it kind of uses this triangle model where it looks at the connection points and how we can help the client to intervene and assess how my thinking is impacting the way I feel, and how I feel might be exacerbated by the way I'm thinking, or vice versa. And so this might look like someone thinking I'm a crappy parent, right? And that causing shame and guilt and wanting and causing them to then maybe have an urge to use to manage those negative feelings. We might look at shifting that thought pattern to I'm growing as a parent, right? To help neutralize some of that feeling and maybe minimize the urge that may come up. And then we have the tailored to the needs of the client, right? Remembering person-centered practice is going to be so important, because while we're talking about statistics and correlations and pieces we want to consider, these are elements for us to have in our back pocket and in the back of our minds, but we want to use some open-ended questions to help explore how it relates to the specific person sitting across from us, right? What is this woman that we're working with experiencing in their particular lives, so that we're able to tailor the treatment and the use of cognitive behavioral therapy in all of our treatment planning with the participant that we're working with. So logistically, there was a wide range of settings that were found. It included healthcare settings, inpatient settings, psychiatric rehabilitation settings, community outpatient programs, in addition to virtual formats. It was also used across genders, ages, races, and ethnicities. And the practitioner types included those who were trained in the principles of CBT as behavioral health professionals, primary care staff, and criminal justice personnel. Similarly to the motivational interviewing, there is training for professionals and non-professionals, or clinicians and non-clinicians, that can be utilized. So typically with cognitive behavioral therapy, it's customized to the needs of the individual. It usually lasts between 5 to 10 months for about 50-minute sessions, and is rarely done in a group format because of the individuality around the way that faulty patterns of thinking or unhelpful thinking patterns can emerge, and the vulnerability of sharing our thought patterns, etc. The outcomes, they found reductions in the quantity of stimulants being consumed per week, reductions in the frequency of stimulant use per week, in addition to reduction in risky sexual behaviors. And so again, we're seeing that all four of these models are models that are helping to reduce the use of stimulants, that reduce the risk and dangers that we saw earlier. So when we're thinking about considerations around and using these evidence-based model, we might include practice selection, right? Is the setting appropriate? What particular role that we find ourselves in. Funding may be a challenge. Finance and program costs could be another challenge. Program staffing, coordination of care, and cultural adaptation, right? So these are some barriers that can potentially exist. And then which one is that? There's one of the references here that actually also walks through some ways that we can address those specific barriers as well. Contingency management can be used in the beginning stages and combined with other therapies, such as the community reinforcement approach. CBT can also be used in successful at any stage of recovery. When we think about pre-contemplation, contemplation, action, and then maintenance, right? Those different stages in which we help our clients work through. CBT can be helpful at any and all of those stages. Similarly, motivational interviewing can be helpful throughout treatment, but also at the beginning of treatment, because it really helps build a wonderful, safe context for that relationship between you and the woman you're working with, so that you can have the outcomes and the safety needed to address such a stigmatized challenge, right? Especially when we think about the outcomes and the consequences of substance use, that furthers the stigmatization of use. So these resources here are for you all. There are hyperlinks, so you're able to go directly to the link. The Academy of Cognitive and Behavioral Therapies has training for people who are both clinicians and non-clinicians around how to use the cognitive behavioral therapy model. The Beck Institute also has some training around cognitive behavioral therapy as well. And we have the contingency management webinar at the bottom, which is a training on using the contingency management model. The Chestnut Health Systems EBT X Center offers training and the contingency reinforcement approach. Community reinforcement approach, as well as the adaptation for adolescent populations. Prism Collaboratives is an opportunity to get additional training on the contingency management, in addition to the Motivational Interviewing Network of Trainers, or MIT, as another organization that can help us in understanding more around resources and trainings for the use of motivational interviewing. Then these final two resources here are summarization, or like summaries of article summaries, if you will, that express the treatment consideration for women, more specifically around some of the trends that are existing and the considerations that we want to have when we're working with women who are using substances. I'm going to come out of here, stop sharing, see if I can get my camera to work. Okay. Huh. Hi, everyone. Okay, so do we have any questions in our final few minutes here? Thank you. Thank you. Okay. Well, thank you, everyone. So I will turn it on over to Rebecca if there are no more questions. I appreciate all of your commitments to being here today in this 2-hour training this early morning, and your commitment to your clients and understanding women's specific needs. Y'all have a wonderful day. Stay safe.
Thank you so much, Elle. I hope you can see all of the comments in the chat. I think you can. Of course, as usual, you get great remarks. You always put on such a wonderful webinar for everyone. We thank you so much for that, Elle. And so everyone knows, we have included Elle's contact information so that you may contact her with any further questions. And we have a couple of items of business to note before we conclude today's webinar. Please see the chat panel for a link to today's evaluation. If you want to receive CE credits or statement of credit for this event, you must complete this evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must have provided an accurate Florida Department Health license prefix when you registered for this event. After you register or sign in, you will be directed onward to the evaluation. You must use the same email address you used when you registered for our webinar and what you have set up in your VADA profile, as this is the only way to connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. The evaluation will close midnight, Tuesday, March 7th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 days after the evaluation closes. If you have questions on how to find your journal entry, please see our CEU frequently asked page for information and help with that. Thank you for participating in today's webinar. We'd also like to recognize and especially thank the Florida Department of Children, Families, Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day. Please hold for the evaluation. Thank you all.